for Safe Community, which is an Alternatives to Incarceration program that practices in the state of Illinois in the United States, but also does national consulting with regard to criminal justice and public health. Having said that, this is the second panel that does deal with the nexus between crime and drugs and the need to integrate public health into our criminal justice system. And we have some distinguished panel members, some of whom are my very close colleagues and friends, and I've told them to behave themselves and to be articulate in what they say and do. I hope that there are some of you, I think, who were in the previous session, which was Alternatives to Incarceration, and this is the same kind of theme, and I think you will hear the same issues. So feel free to just kind of ask questions both from that and as well as this. And I want to begin with one of my esteemed colleagues, Antonio Lomba, who is the Institutional Strengthening Unit Chief and Alternatives to Incarceration Coordinator for the Executive Secretariat of the Inter-American Drug Abuse Control Commission, or CICAD, Organization of American States. Antonio.
Well, thank you so much, Melody. What a pleasure being here and share this panel with these distinguished panelists, all of you. And I'm very happy that this session is coming after the prior one, because the introduction of the prior session will give me some more time to speak about other things and not repeat myself. Before going into details, I just wanted to thank the organizers, want to organize ISSUP, and also UNODC, the rest of the partners, and INL for supporting this. And just one recognition to two people that are behind the scenes, and I know this is thanks to them, Jan over here from UNODC and Diane over there from ISSUP, and a lot of people, but I just want to thank all the work behind the scenes. Sorry if I'm missing a huge amount of people there, but it's important to... Okay, this morning someone said that it's good to...
It should go with the
medium one? The red?
No, it should go this... It's not working. Hi.
Oh, here you go.
Here you go. Okay, just
Which one did you? Okay.
This one. Okay.
Good. So these are the things that I'm going to try to cover in the 15 minutes that I've been given. First is why we, CICAD, the Inter-American Drug Abuse Control Commission of the OAS, is involved in alternatives to incarceration. Second is just to explain, and that's something that was covered in the prior session, but alternatives to incarceration and why this is a public problem that requires a public policy reaction. And just to give a big picture of where alternatives to incarceration are right now in the Americas, generally speaking. Then I'm going to go into the capacity, which is the title of the presentation, the institutional capacity to react and to put in place certain mechanisms that would allow alternatives to incarceration to happen. And I will end up just giving some examples of very concrete things that we as CICAD, we are doing in partnership with other organizations. It's working with you, but not with me. Okay.
Is it working? Okay.
My boss, the Assistant Secretary of CICAD, Angela Crowdy, already presented CICAD, so I'm not going to go into more details. But I think I'm not going to go into the structure and what we do, but I think it's important to highlight that the reason why the OAS is involved is because first, we have an OAS strategic strategy, hemispheric strategy, drug strategy, which has been approved by all OAS member states, which for us is a mandate, and it is for the countries, but it's also for the Executive Secretary to support member states in following that strategy, and concretely with that plan of action, which goes from 2016 and 2020. And there is a lot of areas in that plan of action that covers alternatives to incarceration from many perspectives. And the last thing is all the declarations, mandates, resolutions, UNGAS recommendations, the 7, some of them are directly related to this subject area. And for that, we have a structure that covers from 5 different units, different related areas. We do that thanks to the leadership from countries and also with the partnership with UNODC. Anja was presenting before, UNODC and the whole team in UNODC, with CARICOM, with Coppola program in the European Commission, with Colombo plan, with civil society. So we are able to do this with partnerships with many institutions. and also thanks to the donors that are making this happen in this particular area. But it's important to highlight that we work on 3 different levels, all CICAD does. At the polity level, first, the whole legal framework, and that was explained in the prior session too. Also with the politics and the actors that are involved, and also with the policy. So those three elements on levels of approach. Much was said before, but I just need to say that not all problems, and as you know, become a public problem, and not all problems need or require a reaction from policy. We live with problems all over the place, but some things generate the need for the institution, for the state to react. And there are many that were discussed in the prior session. I mean, the cost, incarceration, judicial system, the perception of citizenships of insecurity. I'm just mentioning a few of them. I mean, the fact that you have, I mean, you mentioned 9 million people in prisons. A huge amount of that proportion is related to drug-related offenses. And we don't know how many, because there are some crimes that are property crimes, and we don't go beyond that and know how many of them are addicted or have any other drug-related issues. So, but at the end of the day, the revolving door happens again and again. The judges are tired of that revolving door, the different actors. And at the end, it's just the system doesn't work. So there is something to be done. And that's why citizens demand, specifically to states, to the institutions, to the governments, to create or generate some kind of a reaction. And for that, and this is the main point, it's just that sometimes we do not have the institutional capacity for that to happen. So that is something that I will go over the presentation, but that is one of the things that we are finding in evaluations that we've done in the region for some of the alternative incarceration. We'll go into that in more detail. There is something that I love this subway map. Melody presented that before. There is not only drug courts, or there's a huge amount of things. There's, from the pre-trial, trial, or post-trial options, there's a lot of subway entries and exits, and that covers many alternatives to incarceration. I love this chart, but the reality is that when you see that implemented in countries, you see that many of these options are just not possible. It's not that countries don't want to. It's not that there is no political will, but many of the obstacles that are there, some of them, and I want to highlight some of them, that are institutional or capacity to make those happen, they're not in place, unfortunately. But there's something you can do about that. But the reality right now in the Americas is the most common alternative to incarceration drug treatment course for adults. More and more countries are getting into juvenile drug treatment course. It was said before, Igor said, it's a different animal. With all respect, I'm not talking about animals, but this is there's a completely different model that requires a lot of actors. We have a person here from INL Peru, Maria Eugenia, who is right now supporting the implementation of a juvenile drug treatment court model in Peru in 2 particular areas. There's a lot of examples in the region. But more and more countries are getting into the juvenile drug treatment course. And why do they go there? And why is this more common? Juveniles first, because there is some evidence showing that 80% of the adults that are in prison at some point when they were juveniles, they were in touch with the criminal justice system or the police in some way or shape or form. So preventing that makes sense. It just makes sense to go into that. And of course, and someone has said before, not only juvenile drug treatment course, there's many, many alternatives to do that, and not only that one. But particularly, there is countries decide to go into drug treatment course, first because the legal landscape normally is there. Either because you do have a law, like Jamaica, for example, has the 2001 Act for drug treatment course, or most of the countries do not have a specific law, but they can adapt and use the legal framework to make that happen. Second is because you can maximize resources and allocate things in a very quick way. And third is because you can pilot. There are things that you can pilot. Now, when you start with drug treatment course, then you realize that you can do much more, and you can go into family course, you can do community course, you want to do diversion, you're going to go deflection, all the things that Melody described before. But the problem is, for that to happen, you need to have other things. You need to have, prosecutors, for example, they do need to have some discretionality to decide what cases, if they can do it, which is in most of the cases they cannot. A police officer that arrests one person for a crime cannot just decide, I'm going to send that person to an alternative. They need to arrest that person. That is the law, and they need to apply. So there is some limitations in that to happen. And the same thing with the prosecutor. Is a prosecutor able to, just don't send that to the court? Sometimes they do, but in many countries they cannot have that capacity. And community-involved programs, and it's the tendency, but at the end of the day, it requires a lot of institutionality, a lot of re-entry course. They were talking about prisons before. When do you start with re-entry? At one point. If you don't have treatment in prisons, I mean, when are you going to start? Are you talking about re-entry just whenever they're exiting? It just makes no sense. So it's complicated. It's just not easy. It's not that countries are not willing to do that, but it's just not easy. Some examples that we see, restorative justice approaches, like in Chile, for example, that they take into account the victim, or in Costa Rica, that they have a similar approach on restorative justice, are in place. Costa Rica, for example, as an alternative to incarceration, they drafted and passed the law, the Act 77, a few years ago, that allows certain women that were just leaving the house and going to the prison to bring drugs to their husbands that were forcing them to do so. They got in prison just bringing the drugs to the husband, and they were, a huge amount of years of sentence right doing that without coming back on the same day to their houses. That is a drama, and social integration has a role there for that. For all this system, there is a big gap, which is one of them is case management, case care management, depending on who is reading. Case management, all the judges understand that. Care management, all the health providers understand that. We need to find that kind of a case care mix. Right now, and I'm not going to go into country by country, but there's, with INL support in particular, there's been a huge expansion of document course in the region. There are 15 member states right now in the Americas that are either exploring or implementing or evaluating the model. I mentioned Peru before. There's Trinidad and Tobago. There's some representatives here that are, there are countries here present that that you are implementing this. But the problem is that whenever you say that the state is going to react, you need to react somewhere. No, this is not true. It's telling me 5 minutes, and I have my work now. It's 7, sorry. No, I put my clock here.
I got my clock.
No. Okay, there are some variables to take in consideration. To what extent a country is capable to regulate, to coordinate resources and authorities and leadership, to what extent is capable of analyzing, and to what extent is capable of delivering results. So I have 7 minutes. Some of the examples of regulatory framework in that sense of capacity has to do with establishing a legal landscape or legislation, to have, an act or not, a policy paper, some kind of a framework under which you can intervene. Coordination, the whole thing, Trinidad and Tobago and other countries, the fact that they may have or not a steering committee to organize certain of these models. Information gathering, and I'm going to talk about that in a second. But what information are you getting, how you analyzing that, are you evaluating what you have in order to base your next step? That is something that has to do with analyzing. And deliverables, you have the tools, the models, the things in place to really be able to deliver. What we do, particularly CICAD, OAS, the Executive Secretary of CICAD, in this field is promote dialogue. All member states sit down with us, and we sit down with them. They're our bosses, to sit down twice a year to decide what paths we take. So we have a political open dialogue. We carry diagnostic study, feasibility studies. We just did 7 evaluations of 7 member states. We do training, a huge amount of training. We train over 5,000 professionals, judges, prosecutors, defense attorneys in the last few years. We develop tools. We've been supporting member states in creating protocols, guidelines for prosecutors, for defense, all the tools they need to implement. And we support some recent actions with the leadership of INL and with the partnership with Colombo Plan and others, like, for example, the alternatives to incarceration curriculum. We are also supporting the case management curriculum that we hope that will help all member states implementing any kind of alternative to incarceration, because it is absolutely needed and required that when you put a person into this process, you need to have a system that will take that individual from the very beginning to the very end and will follow that social integration that Melody mentioned before on this. Okay. See, I put a picture of you in the presentation. I just mentioned this before. I'm not going to go into that. This is the presentation that we did recently about 7 country evaluations in Washington, D.C., in development of manuals, etc. Some of the challenges that we have. We talked about the variables before, the 4 variables. I'm going to go back to that right now. We have a problem of discretionality. Is it good or bad? And this is something to discuss whenever you create that kind of a framework. Do we have the legal framework or not in place? Coordination, one of the big problems that we have is the high rotation rate. We have a judge that is in place in one alternative incarceration and 6 months later leaves. Or the defense attorney rotates, or the prosecutor. There is no way to maintain these people for at least 2 years so the system can be consolidated. And sometimes the chief justices, they say, you know, I cannot force a judge to be here 2 years because I will punish him or her if they do so. You know, they need to follow their own careers and promote themselves. So it's not an easy issue. Then the analysis thing. I mean, analysis means that, and this is crucial, establishing the criteria of eligibility, knowing exactly, base your decisions of your needs and your capacity. That is crucial. And countries get involved sometimes in alternative incarceration because they like the idea and because the whole thing it looks very good, but when you go into details, you need to analyze exactly why you are implementing that particular alternative incarceration and not try, for example, to do with document court just resolving all the issues. You need to have different layers, and there was presentations about that before. 13 minutes still. Okay. And monitoring evaluation, I mean, really evaluating whenever you have a high risk, high need population, what you need for that. If that population is not high risk or high needs, what is the situation? That is absolutely mandatory in terms of analyzing information. Monitoring evaluation, creating baselines, things that you can compare to see if you're making progress or not, and commitment in that kind of analysis to whatever happens or whatever you evaluate that you can take action. The deliverability, I mean, you need to have treatment capacity. There was a lot of presentations this morning about that. I mean, it's good for pilot projects to do certain things, but you need to have a bigger approach. And unfortunately, there was a NIDA research, data saying that in the best case scenario, only 11% of the people who need treatment, they are receiving treatment. That is the best case scenario. Can you imagine so you need to have protocols in place to deliver that. You need to have a case management system, and you need to allocate the resources correctly. These are things that I want to highlight because the OAS just drafted and presented 2 important documents. One is a report on drugs use in the Americas. The other one is the 7th round of the MEM mechanism that they were already discussed this morning and mentioned. Some of the publications and things that are useful for this. One of them, I put it out there almost 100 copies, and they were gone. This is the recent manual on document court monitoring evaluation. This is a unique document that is useful right now everywhere. If you didn't get this, there is also the pen drive that I put outside. Thank you so much for picking that up. And my last 5 seconds, closing, is to thank you. Thank you so much for your time. I really appreciate it. Thank you for your
My clock disagrees with your clock, but that's okay. Our next speaker is Dr. Charlotte Colman, who's a professor for drug policy and criminal policy at Ghent University. Charlotte. Very good. Send me those documents.
So, good afternoon. The following 15 minutes, I will be talking about how the criminal justice system and the community could foster recovery and desistance. I will keep this presentation very, very basic and general, so please feel free to contact me afterwards if you want to have more in-depth discussions about this topic. So first things first, we know quite a lot about the relationship between drug use and offending. And in this session and the previous session, we mainly talk about primary drug users who get involved in the criminal justice system because they have committing offenses under the influence of drugs. They have been committing offenses to finance their drug use, or they have been committing drug law offenses. Now, eventually, we know that most people stop using drugs and stop committing offenses, which is called recovery and desistance. And the thing is, what you have to know about recovery is that several countries use different definitions of recovery. For example, in some countries, they are focusing on abstinence. And in other countries, depending on their policy, they're more focusing on quality of life and decreases in intensity and frequency of use. So it's very important to keep that distinction in mind. but there is one common ground in every country, and that's the fact that recovery and desistance are processes, and that you have different stages of recovery and desistance, and it goes from early to stable recovery. And research tells us that it takes more or less 5 years to reach the stage of stable recovery, and even then it's possible to relapse. So we're mainly talking about persons in recovery rather than persons who are recovered. When we are looking at the components that are leading to recovery and desistance, we mainly make a distinction between 3 components: personal, social, and community. Personal is like, I'm getting older, I want to change, I want to stop using drugs and stop committing offenses. So the personal motivation, the age, the gender, etc. The social component is more like, for example, I've met the woman of my dreams and I want to marry her, so I want to change and I want to stop using drugs. Also, criminal justice interventions, treatment interventions could be seen as examples of that social component. And then you have the community component, and that's more, is the community giving me access to housing and financial means and work possibilities, but also the attitudes and the perceptions of citizens towards people in recovery. So the first part of my presentation will focus on a criminal justice intervention as a social component fostering recovery and desistance. When we are looking today at our criminal justice system, we see quite a lot of primary drug users stuck in that criminal justice system. Now, research tells us that for those primary drug users, recovery is more important than desistance. So desistance is more subordinate to recovery, and when you focus on recovery, desistance follows. Which means that criminal justice interventions should focus on that drug using problem and other life domains, problems on other life domains, instead of a sole focus on that offense and the crime problem. The criminal justice system itself is rather an obstacle to recovery and desistance, especially when we are talking about prison, because it means isolation from friends and family. A criminal record means that it could jeopardize your chances to have a quality job. But the criminal justice system could also provide opportunities to recovery and desistance, and this is what we are talking about in this session and the previous one, namely when we divert offenders from the criminal justice system towards treatment to work on recovery and on desistance. And today, many countries are experiencing or experimenting with alternatives to incarceration. In Belgium as well, that's the country where I live in, and I want to focus on one alternative in particular, that's our drug treatment court in Ghent. We do have alternatives at each level of the criminal justice system to divert offenders at each stage to treatment. So the DTC in Ghent, it has been implemented in 2008 as a pilot project, and up to today, it's still a pilot project. But nevertheless, it was the first DTC in Belgium. It was a bottom-up project. It was the judge and the prosecutor sitting together with treatment, discussing the fact that they needed an alternative at sentencing level to divert offenders to treatment. It's based on the US drug courts, but it's not a copy-paste because we have differences in judicial systems. It's a continental law system. Also, there are other differences as well. For example, we don't have a pre-court hearing, and there is a very strict distinction between criminal justice and health, which means that health providers are not giving any information from treatment to the criminal justice actors. This is the responsibility of the client. It's the responsibility of the client to give information from treatment to the judge. So the trust level between the judge and the client is of utmost importance. We focus on empowerment, and empowerment means an increased responsibility. So it's the responsibility of the client to make up a treatment plan together with the treatment providers and to make it tailored fit to his or her problems. It's holistic and individualized, and we see, for example, that there are many more diversions to non-drug specific interventions, for example, work or health or financial means and employment. We focus on strengths rather than on risks, so we want to empower the strengths of a client rather than focusing on risks of recidivism or relapse. What's also important is the time interval between when you have committed your criminal act and the diversion to treatment, because we know that the sooner a person gets diverted to the criminal justice system, the better the outcome. When we compare a DTC trajectory to probation, we see that a person gets into treatment in a DTC trajectory after more or less 6 months, while in probation it takes up to 22 months before there is any treatment. There are some threats as well in our DTC, and those threats are relating to especially the screening of the profiles of the clients involved. So this needs some re-evaluation in our Belgian DTC, like which profile are we letting into the DTC? Isn't the DTC a too intense program for some of the offenders who are currently in our DTC program? The start of a DTC was accompanied by evaluation studies. We had process evaluations and outcome evaluation. That outcome evaluation showed some positive results, especially regarding recidivism in 80% of the clients. There were no significant effects regarding decreases of drug use. And this is something that you see quite often in evaluation studies on alternatives to incarceration or punishment. But that doesn't mean that there isn't any progress. It only means that there is no data available on the broad definition of recovery. For example, in this study, we only looked at prevalence of drug use before and after the intervention. We didn't take into account the intensity of use, the frequency of use, the method of use. And based on the quality interviews, so the qualitative research, we know that there is some change in intensity and frequency of use. Psychosocial functioning, really important, especially when you're thinking about evaluating your alternative to incarceration. Please bear in mind that you also include some psychosocial functioning domains, so life domains like health and social relationships, like work opportunities and financial situation, because those life domains are positively correlated to recovery and desistance, and they are often neglected in evaluation studies. The second part, I will be very brief, will be how we as a community can foster recovery and desistance, and maybe this answers some of the questions that were raised by the audience in the previous session. It's the third component, so the community level. So in the beginning, we as researchers, we mainly focus on the personal and the social components of recovery and desistance. But today, there is an emergent trend in academia to focus on the community, because there is a very big difference between wanting to change and being able to change. And that change and that support by the community is a very, very difficult one. We see that there is a lot of stigma and discrimination towards active drug users, but there are almost the same levels of stigma and discrimination towards people in recovery, which means that a lot of citizens don't believe that recovery is possible. And that's a problem, because although recovery and desistance, these are personal journeys, but they happen in a social context. And the hardest part of recovery and desistance, especially to sustain it, it happens in the community. It happens after your criminal justice intervention, after your treatment intervention. And therefore, together with the UK colleague, David Best, we were thinking, okay, how can we, as a city, promote recovery and desistance? There must be something we can do in our city to make a change. So we elaborated on the idea of inclusive cities, recovery cities. And the idea is that nobody should walk the recovery path and the desistance path alone. And it basically means that we make recovery and desistance visible in our communities and that we celebrate it. Because we celebrate a lot of things in our lives. We celebrate marriages, even sweet 16s, and I'm even throwing a party for my 2-month-old baby girl on Sunday, and she doesn't even realize it, the party is for her. So the thing is, we keep recovery, and desistance, which are major accomplishments, we keep it hidden in our societies. And only the negative consequences of drug use and crime are visible. For example, needles in the park, that's very extreme, but also drug-related nuisance or drug-related crimes. The thing is, if you make it visible, you have something like recovery champions. And the recovery champion, it means that you make recovery visible and possible to people who think recovery isn't possible. Basically, the idea of a recovery city or an inclusive city is that you bring people in a city who are working on different life domains relating to recovery and desistance, you bring them together. These are the city council, financial organizations, housing organizations, criminal justice actors, treatment providers, citizens. People in recovery and desistance are sitting around the table and they are thinking about initiatives to implement in their city to foster recovery and desistance. And today, several examples exist, and several cities have said that they want to become an inclusive city. For example, Gothenburg, Ghent, Sheffield, etc. And you don't have to, you don't need a lot of money to be or to become an inclusive city. You can, for example, organize recovery bike rides or recovery walks. If you have more money to spend, then you can make some structural changes. For example, Jobs, Friends and Houses is a social enterprise, and they learn the skill of renovating buildings to people in recovery and desistance. They get a job, they get paid to then renovate buildings in their neighborhood. So it's good for the neighborhood and it's good for people in recovery and desistance because they are learning a job and they have a very quality and decent job as well. I need more time to discuss with you how an inclusive city works. But we do have a website, so if you're interested to learn more about inclusive cities and how you can become an inclusive city, please feel free to visit the website and you can register and then we keep you informed about updates and all initiatives we are taking. I've listed some take-home messages because in 10 minutes I have a tendency to talk too much and then too fast because I want to share a lot of things with you. So these are the take-home messages and thank you. It was lovely to be here.
Now I have the pleasure of announcing another wonderful colleague of mine, Dr. Mariano Montenegro, who is the director of the Colombo Plan Office for Latin America and the Caribbean and UNODC Drug Demand Reduction Policymaker Training. Mariano.
Okay, thank you very much for this invitation and sharing with this distinguished panel. Thank you, Melody. And this is a fantastic subject. I love this subject, and I am completely in love with that because it's a big, big need, no? And I want to know the reality in our region. Antonio Lomba showed part of that, but I want to mention this Regional Human Development Report in 2013-2014 in the UNDP, Citizen Security with a Human Face, no diagnosis and proposal for Latin America. Behind the crimes and violence respond to a Latin American paradox. We have a big paradox. Why, in spite of the advances in regional growth and development indicators in the last decade, has objective and perceived insecurity increased. This is our reality, and this is number one of our number one problem in Latin America: violence, crimes. 4 sets of variables allow us to explain the vulnerability of Latin America to crime and violence. 4. They could study that, and they mention 4 important variables. The economic structure, that has conditioned economic growth without quality, and focus and consumption, insufficient social mobility, and even generating an aspirational crime. This is a new type of crime. It's an aspirational crime, not for eating exactly, Changes in social institutions, such as the increase of single-parent family, high school desertion, and accelerated urban growth. 3, our subject, the facilitators, weapons, alcohol, and drugs. 4, unfortunately, corruption, the lack of institutional capacity of the Latin American state, especially in the area of justice. So the situation in Latin America and the Caribbean is quite difficult in this subject. No, Latin America and the Caribbean have high crime rates compared to the world and high rates of drug use. So we have both problems together in a very high rate. For citizenship of this continent, public safety and phenomenon of drug are priority. Wherever you are, in every single population, every single country with every single government is number one. The government of this region must respond to this priority need of citizens and be effective. If not, they are not going to be in charge. These two phenomena, that of citizen insecurity and that of drugs, cause a lot of social suffering. And among many things, it also destabilizes democracy. In this region of the Americas, there are few alternatives to incarceration. You, Antonio, told us. Very few alternatives to incarceration. It's generally the prison, the fate of a convicted. So this is the solution in general in our region. This is my country. I want to show one experience, interesting experience, because I want to give hope, because a small country can do some things. This is a long spaghetti, no? And in the south of the world, and this is my country. This country has a population of 17.5 million, with 7.5 million in the capital, very centralized, 16 regions, and 350 municipalities, and $23,000 per capita. It's a middle-income country. This is our reality, middle-income country. No, it's a low-income country. No, I want to explain that because this is one condition. Maybe we can do it. We are using, like you explained before in the panel before, this model is, we are in this model now, we could convince. So this is the risk, need and responsibility model is being applied in Chile in problematic drug user in conflict with the criminal justice system. We started. In Chile, the consumption of drug is not criminalized. This is very important to know, no? First. Therefore, this model applied to offenders of ordinary crimes that also present a problematic use. It's applied at different moments of the criminal process. There are 100,000 people sentenced, 40,000 are in prison, and 60 people in sentence in alternative to incarceration. This is a good news, because now we started with 50-50 and 60 in prison, 40% in alternative, and now we are moving to alternative to incarceration. This is a good news. In Chile, there is a system of alternative to incarceration, and now these alternatives are being given content. This is important, no? Alternative, but what? What are we going to do like an alternative? Because the citizen need to know what are you going to do with this guy? Because if not, it's impunity. This is the feeling, no? Especially if there is a problematic consumption. If there is an alternative to incarceration without program that guarantee rehabilitation and reduce the risk of recidivism, for the normal citizens, it seems impunity. And it does not support it. Citizens would prefer jail. So we have to convince them this alternative is with good content. We are completely committed with we reduce the recidivism, and they can understand that, and they accept that, the normal citizen. So the treatment and rehabilitation program in a population with problematic use of drug in conflict with the criminal justice system in my country, we have these 5 alternatives. Drug courts, of treatment in adolescents and adults offenders of criminal law, ordinary crimes that also have drug consumption. In Chile, it's not a crime to use drug. No, I want to confirm that. Drug treatment, rehabilitation, in probation. We started 7 years ago. And we started with drug court in 2004. So 15 years ago. Drug treatment and rehabilitation in parole. Now, exactly now we are starting. Approve the law, not yet implemented. We need some steps, and we are going to implement in the end of this year. Treatment and rehabilitation of drug in adolescent offenders in prison and in alternative to incarceration with the same model, R&R. Drug treatment and rehabilitation in prison for adults with gender perspective. We can offer now for this group of population this alternative. So the treatment description in treatment center specialized in problematic use in prison. Stage of high threshold treatment, adaptation, first stage, treatment by access, preparation for graduation, follow-up, post-release from prison. The access in treatment are consumption pattern, comorbid mental and physical disorder, criminological dimension. It was not easy to put this variable in the team. Support network and social integration. Drug treatment and rehabilitation model and a social integration in a population with problematic drug use in conflict with the criminal justice system. We have a comprehensive diagnosis first, and the intervention plan. First, repair. Second is responsibility and habilitation of competences and social integration. This is the model in general with this profile. And we evaluate an offender with problematic use of drug, know the pattern of use, drug use, of course, biopsychosocial area, all this area. Obviously, the previous existence, appearance, or reappearance of conflict with the justice, and the criminal thinking, and motivational state. All the time, this is the protocol for the evaluation in each offenders. So, this is treatment, but we need to include recovery, because recovery is, you, Melody, told us, because treatment and rehabilitation is not enough, absolutely not enough, inclusive with this profile. This profile is very, very abundant. So we need to be very, very concentrated in recovery. Recovery is for a long period, not a short period. Exclusion is very important in this profile, so social integration is important. And recovery, we have the same description with SAMHSA, and M24 Institute also. It's quite a general explanation. But exclusion is a person is socially excluded if is prevented from participating fully in economic, social, and civic life, or if his income on other resources, personal, family, and cultural, are so small that they prevent him from enjoying a standard of living considered acceptable by the society in which he lives, or she or he lives. Combination formed by the lack of economic resources, social isolation, and limited access to social citizen rights. So exclusion is cover the dimension, economy, political, legal, and social relational. Impediment to participate fully, that which is considered acceptable by the society in which they live. So we are concentrated in deficit, or we are concentrated in capacity. And this model is we are concentrated in capacity. This is very important to see, because they have enormous amount of deficit. We are concentrated in deficit, we have huge list of deficit, but it's really not the principal focus. The principal focus is capacity, so for the recovery. So we are talking about, and we are going to talk about in CCM, in alternative to incarceration, reintegration, insertion, inclusion, reinstatement. We have to talk about that, because most of them never ever have been included in our society. So definition is a process of mutual change. You told us about community, very important. It's a mutual changes both by the person himself or herself and well as by society. It means the contribution of those affected and of the community to achieve an equalization of opportunity which allow equality and full participation of people with problematic substance use in life and social development. I love the concept inclusive city. This is fantastic because if we can get this concept, if we can put this concept in the mayor, maybe we are going to talk seriously about that, no? The challenge is multi-sectoral. It required a case management method, Elisa, a case management method that facilitates this integration with the different sectors. The case management professionals must have knowledge and skill in social vulnerability, problematic drug use, criminology, mental health disorder, management with different sectors, good and social skill, knowledges and gender and sexual diversity. We have team in CCM, case care management. With this condition, we need to have this level of knowledge, this level of skill, okay? And management of permanent motivational techniques, always. In summary, talking about social integration is talking about a bilateral process, affected person, society of mutual accommodation, inclusive city, participation of all social space and equalization of opportunity, rights and duties. Thank you.
Thank you, Mariano. We have the privilege of having an added member to our panel who is going to give us a very important report, and that's Mr. Kamran Niaz, who's in the research section of UNODC Epidemiology, who will present to us the UN drug report overview findings, especially with regard to a focus on prisons. Thank you, Mr. Niaz, for joining us.
Thank you, ma'am. Good afternoon, ladies and gentlemen. It's the end of the day, so I hope I would not bore you with lots of data. Anyway, since the World Drug Report 2019, which is an annual publication of UNODC, was launched just last week, I was asked if I could present some of the information from the World Drug Report regarding drug use and drug use disorders in the prison, but also give you some of the highlights of the findings in the World Drug Report itself with regard to drug use in community settings. So you'll see my presentation containing both of those sets of information. The first slide that you see is one we put out almost every year. Each year we try to present the best information, best estimate that we have on the extent of drug use globally. And what it essentially tells you is that in 2017, we estimate that there were 270 million people, or about 5.5% of the population aged 15 to 64 who had used drugs in the past year. Whereas we had about 35 million people who were suffering from drug use disorders. If you look at the trends of drug use, of the extent of drug use over the past few years, you see a more or less a stable trend. But if you compare the trends over the past 10 years, what we find is that the extent of drug use has increased about 30%. The number of people using drugs has increased by 30% over the 10 years period. Whereas if you account for the increase in the global population, that had increased by 10% over the same period. Looking at the data on people in treatment, we all know that the access to treatment is very low globally, and we estimate that around 1 in 7 persons with drug use disorders receive treatment in any given year. If you look at the extent of if you look at people in treatment, it gives you an understanding of what is the major drug of concern in each of the region, and therefore you see cannabis has been a drug of major concern in Africa, and you see opiates or opioids as drugs of concern in Asia. Again, if you look at the longer term trends of treatment demand, two things kind of stand out. A, that the treatment demand for cannabis use disorders has increased since 2003 across most of the regions globally. And another thing that we have seen is the displacement of opiates with amphetamines or methamphetamine in particular in Asia in treatment demand. Moving on, we estimate that about 11 million people inject drugs globally. Out of those, 1.4 million are living with HIV, and nearly half of the people who inject drugs are living with hepatitis C, and about 1.2 million living with both. In terms of the extent of people who inject drugs in HIV, globally you see a higher prevalence in Southwest and Central Asia, and then East and Central Europe kind of stand out as the two sub-regions with high prevalence of people injecting drugs and living with HIV. This is based on the data from the Institute of Health Metrics, and the estimates are that more than 500,000 people had died because of drug-related drug-related causes. Among those, nearly half of the drug-related deaths in the past year were attributed to untreated hepatitis C. But if you look at the deaths due to drug use disorders, then opioids stand out and account for 60% of the global deaths due to drug use disorders. Again, if you look at the disability-adjusted life years or healthy years of life lost due to disability and premature death, you see both hepatitis C accounting for nearly half of those healthy years of life lost among people using drugs. But then again, if you look at drug use disorders, opioids kind of like stand out as a major substance of concern with the major burden of disease globally. Coming to the prison and drugs in the prison, globally there were estimated that around more than 10 million people are in the prison systems at any given time, and this includes people in pre-trial detention, detention centers, prisons and jails, which corresponds to about a rate of 150 people per 100,000 population. And if you look at the distribution by the different regions, you see that the highest rates of people in prison are in the Americas, which go to over 400 people per 100,000 population. Although the rate of people in prison in Asia is lower than the global average, you see because of the population, you see the largest number of people in prison settings because of drug-related offenses are in Asia. So out of those 10 million plus people in the prison settings, you see the large majority, 9.6 million people, are men, whereas women comprise of a smaller number of people in prison on drug-related offense. But if you look at the proportion, nearly 35% of women are in prison settings for drug-related offenses, as opposed to just 19% of men who are in prison for drug-related offenses. Prisons also remain a high-risk environment of both drug use and infectious diseases. And if you look at the extent of drug use in the prison settings as compared to what is in the community, we see nearly 30% of people in the prison would have a history of drug use in their lifetime, and nearly 20% would have used drugs in the past month. And if you compare with 1% of people using opioids in the community setting, you find that 5% of people in the prison settings would have used heroin in the past month. Also, based on the literature review in high-income countries, nearly 30% of men and 50% of women in prisons would have had a drug use disorder in the past year before being imprisoned. Also, if you look at the extent of drug use, extent of people injecting drugs in the prison settings, what you see is that in many of the regions, 1 in 5 people in prisons have injected drugs while being incarcerated. Similarly, if you look at the extent of infectious diseases in the prison, the rates are much higher in prison settings than in the community setting. So globally, it's estimated that around 3.8% of the prison population are living with HIV, and around 15% with hepatitis C, and around 2.8% with active tuberculosis. But if you compare the prison population and compare those who are injecting and not injecting drugs, you find that the rate of HIV among prison population who are injecting drugs is 6 times higher than those who are not injecting, or the rate of HIV among people who are injecting in prisons is 8 times higher than those who are not injecting. Moving on, if you look at the extent of services for opiate substitution, needle syringe program, HIV testing and treatment, hepatitis C testing and treatment, or treatment for active tuberculosis, you see just a few countries that would have reported that such services exist in nearly half of their prison settings, and the green part that you see is where those services are available in less than half of the prison settings. But in the majority of the countries, you see that none of these services exist at all in the prison settings. Moving on to another area, when you look, we look at the whole market of new psychoactive substances remains quite dynamic and diverse, and each year you see a number of substances that come in, but there are many substances that also phase out of the markets. And what we see essentially is there are about 500 new psychoactive substances that have kind of like remained within the market for longer than a year. This year, one of the main concerns that we have had is also keeping in mind the global opioid crisis, that nearly 30% of the new psychoactive substances that were reported to UNODC were opioid receptor agonists. In this chart, infograph, we try to explain to you the broader expanse of the use of opioids globally, and where on the one hand we see the use of what we would call as the traditional and conventional opiates, heroin and morphine or opium. You also see a misuse of pharmaceutical opioids, but then there's also the fentanyls and fentanyl analogs who are coming in, some of those that are as part of the international control, and there are others that are not. And then at the very extreme right, the small circle you see are of those that are of the research opioids that were kind of like developed initially by pharmaceutical industry, but were never marketed for medical purposes. And many of those research opioids are also making their appearances in the market as substitutes or alternates to opioids. We look at lots of people have talked about. Okay. Lots of people have talked about the global opioid crisis and what we see and what we know about North America, that there has been a considerable increase in overdose deaths related to opioids. But what not many people kind of pay attention is the opioid crisis in Western Central Africa, North African parts of the Middle East, where it is led by the non-medical use of tramadol. We have information mainly from Nigeria itself, where we estimate about 4.5 million people had used opioids in the past year. But one indicator of the extent of how much tramadol is in the region is that in 2013 there were about 8 tons of tramadol seized, whereas in 2017 this had increased to 111 tons. So that's the amount of drug. So that is an indicator of how much it could be misused. So this is just a trend chart of how the opioid crisis looks at in North America, and most of you have seen this, so I don't need to explain much over here. This is the extent of opioid crisis in Western Central Asia, where you see most of the Western Central Africa, where you see most of the countries within the western coast of Africa are experiencing some kind of an opioid crisis, which is led by tramadol. Again, you see opioid crisis also in other regions where we have seen a tremendous increase, considerable increase in non-medical use of pharmaceuticals, especially in Chile, where it increased considerably over 2014 and 2016. While the opiate use in Europe has remained at a high level, it started to increase again over the past 2 years, but not to that same extent as in North America, but you also see an increase in overdose deaths that attributed to opioids, and especially fentanyl, and some of the European countries as well. With an increase in cocaine production globally, you also see an increase you also see an increase in cocaine use in the major markets, both in North America and Europe. Similarly, we also see an expansion of methamphetamine, especially in East and Southeast Asia, where you see an increase both in prevalence of methamphetamine and in treatment in Thailand, for instance, or increasing prices in many of the countries in the region. Similarly, you will see a further expansion or increase of amphetamine consumption, expanding both in North America and Europe. With this, I would conclude my presentation. You can find most of this information in much more details and all the country level data at the link that is given there. And thank you very much for listening to me. Thank you.
Thank you, Dr. Niaz, very much. And thank you all. It is it's just past 5 o'clock. I don't have my glasses on. And I know how tired you are, and you've been a remarkable audience. But I do want to leave the opportunity for questions. But before I do, I want to formally thank UNODC, the Colombo Plan, CICAD, and INL for beginning to focus so much on this issue of drugs and crime, the nexus, the integration of public health into the criminal justice system, and the development of programs or alternatives to incarceration as a systemic initiative. So I really do want to congratulate you very much. Thank you. Having said that, are there those who might have questions? Please feel free to raise your hand. I realize you're also free to leave. You don't. Any questions, concerns? You've got somebody up? Igor. I'm sorry, Igor. Yes.
I just want to make a couple of very quick comments. You know, I think we need to be real here. What is it that we are facing? Unfortunately, the public attitude in general toward people with substance use disorders is send them away, get rid of them, lock them up.
Igor, speak a little bit closer.
Yes, sure. Lock them up, get rid of them, so we don't want to have them around. The government members, many of government members are very much concerned how to be re-elected, and they're willing to go with that. Even though many of them know that this is not the best idea, and many of them know that this will cost an enormous amount of money. Very quickly, the governments are subjected to another dilemma because they're pressed by the public with the question, why are you spending so much money instead of doing something else? So in fact, we are serving three masters: the public health, public safety, and the public budget, and it's almost impossible to satisfy all of them. This is why for instance, the policymakers training that the UNODC is running, supported by the ANL, is critically important. because being a government member and being competent are two different things. And in this case...
They may be mutually exclusive, but that's not...
Well, sometimes they're not the same.
Yeah.
This is why it's so important, the work that you are doing, and thank you, the INL people, for supporting that. One more comment. All of the criminal justice organizations around the world, particularly prisons, they all have incapacitating effect on people. This is just the opposite to what we want in addiction treatment. This is why the work that Dr. Charlotte Colman presented is so important. And I was very impressed by what you said. And lastly, a very small comment. From the research perspective, when we talk about recidivism as a measure, as an outcome, it is a really tricky thing to do because there are different definitions of recidivism. Reoffense, reincarceration, reconviction, rearrest, or maybe something else. So when we talk about data using the recidivism as a measure, this could be very contradictory. The findings could be very contradictory. I think we need to use, in addition to criminal justice recidivism, measures like social functioning, improvement in general functioning measured by measurable indicators, prevention of complications, HIV, TB, homelessness, and many others, and respect for human rights. Thank you.
Very good. Thank you, Igor. Oh, yes, please. Oh, what? Okay. We have. I just want to respond, Igor. I think that question in the previous section, we had the woman who asked about how do you deal with community reaction. What you spoke to really does, in some ways, affect how one develops programs with a political sensitivity to what kind of data you need to develop and publicize, depending on the stage of the criminal justice sector development that you're at. And it may be that you want to simplify it for the community. You know, less crime, reduced recidivism in that way. But as it grows, the other factors with regard to social integration and everything else you said are really, really important. Yes, further, an announcement.
Yes, hello everyone. I'm Livia Edega with ISSUP, and I just wanted to make a few announcements, especially for tomorrow. So first of all, we'll have another day packed with plenary sessions, so please join us tomorrow. We'll start the day out with evidence-based drug prevention programs, so that's the one in the morning, then we'll have a quick break, and then we'll look at new innovative ways to addressing the treatment of substance use disorders. And then our final session from 2 p.m. until 3:30 will be from research to practice, improving drug prevention and treatment programs throughout the development of the workforce. And then we'll have a half an hour break, but please stay on, because from 4 until 5, we're having our closing and award ceremony. So for the second time, we'll be giving out awards for initiatives, for programs, and for individuals. So please stay for that. And we also have attendance certificates for all of you. So if you stay until the end, until 5 p.m. tomorrow, you will get your attendance certificate. And then I also wanted to say, I don't know if you've seen, today at the poster session, we have one section which is an in memoriam wall. And this is really dedicated to the people that have worked in the field but have unfortunately passed away. So if you know anyone, if you would like to add your tribute, if you have a photo or a message, please, it's downstairs next to the posters, so you can still do this until the end of the week. We'll have it there until the end of the week. Yeah, and thank you so much for staying until the end today. Please stay also tomorrow until the end, and yes, have a lovely evening.
This audience ought to get the gold certificate. It's
yes,
past
exactly.
5 o'clock, so thank you.